Let's do the four muscles that we started with in lab yesterday, which is largely going to dominate the anterior chest wall here. So we just started our dissection. The first muscle most of us came across is going to be Pec Major, if it lets me ever click on it. Anyway, so Pec Major is going to be the broad flap-like muscle that we see over here on the anterior chest wall. When we isolate it, we can get a little bit of a better appreciation of the path that it takes. So it starts kind of medially along the sternal border and then occupies the proximal third to proximal half of the clavicle, where it will eventually go and terminate on the lateral aspect of the humerus there by kind of a bony projection called the greater tubercle. So what does this big broad muscle do for us? Well, it crosses the shoulder joint, and the shoulder joint has quite a few planes of motion, so it's going to have quite a few actions with it. The first motion that we see is flexion about the shoulder. The next one that we also see is it'll abduct the shoulder when we do it kind of a transverse plane and we see it pulling a little bit closer to midline. And the other thing to keep in mind too is that muscle crosses anterior laterally. When it shortens or pinches, it causes the humerus to roll in. So our three actions of Pec Major are going to be flexion about the shoulder, adduction, and then also internal rotation. Well, what about innervation for it? We're kind of in a weird spot right now when we talk about innervation because eventually we're going to learn the brachial plexus and all the nerves that come off of it. Brachial plexus supplies all the big motor neurons that will eventually go and innervate our skeletal muscles of the upper extremity. But for now, we have to treat it as a little bit of primary information. So kind of just take my word when I say Pec Major is innervated by two nerves. There's going to be a medial and a lateral pectoral nerve, and they're not so much arranged for their anatomical, or they're not named for their anatomical arrangement when we get down to the level of the pec, but rather the cord that they derive off of the brachial plexus. So just keep in mind that Pec Major is innervated by both the medial and the lateral pectoral nerve. And then we go to the last kind of area I talk about is going to be blood supply. So when we highlight some of the blood supplies, it gets blood from a lot of different places because it's quite a broad muscle there. We see the superior thoracic artery, we see the lateral thoracic artery, and we also have a named branch, which is going to be the pectoral branches coming off the thoracoacromion trunk. There's also some of the branches that go kind of anterior or like kind of perforate off of the internal thoracic artery. So these big muscles that cover a lot of surface area can collect blood from a lot of different places. So that's going to be our most superficial muscle. And then beyond that, we can go on to a little bit deeper muscle. So also as we kind of reflect or pull away Pec Major, we'll see the other pectoral muscle that we care about. And if it lets me click on it, is going to be Pec Minor. So Pec Minor, a little bit different than Pec Major, quite a bit smaller, and interestingly, it doesn't cross the shoulder joint, but rather stays fixed to the clavicle, the scapula. And specifically, it attaches to the coracoid, or that C-like projection that we see as a part of the scapula. So there's three muscles that we'll learn that eventually attach there. That's one of those three, and I think it's worth knowing part of its attachments. The other kind of exciting thing that it does is it attaches anywhere to some of those anterior ribs. They usually say ribs 3 to rib 5. There can be a little bit of variation. What does it do? Well, since it doesn't cross the shoulder joint, it doesn't have a lot of motion about the shoulder. So it's not going to be a flexor or a rotator, an adductor. But what it can do is it can pull down and kind of anchor that scapula by pulling down onto the acromion. I think they'll say some places that it can assist with actions like protraction, for example. Excuse me. So let's see what they say here for action. Protracts and downwardly rotates the pectoral girdle and acromion clavicular joint. Wow, really special there. But I think the thing to keep in mind is that when we talk about innervation and blood supply, Pec Major gets innervation from both the medial and the lateral pectoral nerve, whereas when we talk about the innervation of medial pectoral nerve, some places will say it only gets it from medial. And specifically, they say it only gets it from medial because sometimes we can see the medial pectoral nerve penetrate through Pec Major. Some of you guys in lab actually had that yesterday when we were looking at stuff. So that's one of the differences, at least on the test. Sometimes I like people knowing is Pec Major receives innervation from both. Pec Minor has at least innervation from medial pectoral nerve. We can actually sometimes see it penetrating through. Similarly with blood supply, not too much different on this bad boy. It's going to receive blood from the areas that are around it. So some of the things that are around it are going to be part of the deltoid branch, part of the pectoral branch, and then also some of superior thoracic there, some of which we'll learn later when we start talking about the thoracoacromion trunk and the specific branches that come off of it. So we're halfway done. Let's get one of the tiny ones out of the way. Oops, not platysma. Let's hide that. And let's go up here to subclavius muscle. Doesn't do a lot. Stabilize the clavicle. It sits kind of below the clavicle. It's a little cord-like muscle that we can see. Not too thick, not too long. If we have any of the prosections where the clavicle's already gone, unfortunately, this muscle is probably cut. For actions like we talk about, it'll stabilize the clavicle. It actually has its own nerve coming to it, and that's going to be the nerve of subclavius. So that'll be nice and easy to remember moving forward. For arteries, though, it is worth knowing when we talk about it. It has its own named branch coming off the thoracoacromion trunk as well. So that's going to be the clavicular branch of the thoracoacromion trunk, and then also suprascapular artery, kind of paths posterior to it, so it can give some blood there too. The last one, and something worth spending a good amount of time here on, we've done Pec Major, we've done Pec Minor, we've done Subclavius. That's going to be Serratus Anterior when it lets me eventually click on it. So serratus anterior kind of takes a little bit of a funky path there. If I were to describe it, it's a very deep muscle that originates on the medial scapular border, and it paths kind of anterior laterally till it eventually gets kind of anterior, kind of lateral chest wall there. It makes these finger-like projections that follow the ribs almost. So what does it do for us? Well, it kind of creates an anterior force that keeps the scapula. This is the posterior chest wall. This is the scapula, kind of creates it so it's well adhered and doesn't float out into space. We don't have really a bony joint that connects the scapula to the rest of the chest wall, so it's kind of anchored down by some muscles there. So for some of the other actions that it talks about, it'll say that it can protract the scapula, so kind of pull it forward. It can also upwardly rotate it on the shoulder girdle. I don't care too much about that. I like to imagine that it just keeps it well adhered to that posterior chest wall, because when it doesn't work, we see a phenomena where it'll wing out, or it'll look like the scapula is kind of sticking out more posteriorly and angled than it probably should be. So once again, we kind of keep in mind that this thing takes a really unique path. It sits very like just immediately superficial to the ribs. And there's actually a fun cross section that we can show when we're all done with this. But first, let's cover some of the other things for it. It receives innervation that, say, is worth talking about there. There's a very, very long nerve called the long thoracic nerve that almost goes down like perfectly in that mid-axillary line there. That nerve supplies latissimus dorsi, and for USMLE and other like kind of clinical vignettes, they like to paint a picture of this nerve gets damaged because it represents, or it can show that winging of the scapula, which is that cool phenomenon we can see when this muscle doesn't work. But the question I'd probably write is, we have a 45-year-old female who underwent lymph node biopsy, kind of extending up into the axilla there. After that biopsy, you observed some winging of the scapula. What nerve was likely damaged during that? And that's kind of trying to paint you the picture of the geographic region we're talking about is a nerve that was in this area and it led to winging of the scapula. That's telling me that's probably the nerve that's innervating serratus anterior, which would be injury to the long thoracic nerve. Interestingly enough, as well, there's going to be some blood supply that goes there. The thing that is worth noting where we talk about the long thoracic nerve, it is not the long thoracic artery that goes with it. Sometimes we have neurovascular bundles that share the same names. This is not one of them. It's going to be the lateral thoracic artery, not the long thoracic artery that is there. We also have the thoracodorsal artery and the superior thoracic artery that are close as well. Last thing I want to show, if we can here, is what this looks like in cross section, because I think it looks pretty cool sometimes. So this is kind of cutting somebody in half and doing what we call an anatomical transverse plane here. One of the things I want to demonstrate when we look for serratus and kind of these transverse cuts here, serratus, I like to imagine, is going to be a very deep muscle, which we can see it's the deepest muscle if we're going posterior to anterior, approaching that posterior chest wall, and it's going to be immediately superficial to the ribs. That is worth demonstrating for kind of imaging purposes when we look at other modalities like CTs or cross section, but also helps it when I'm trying to find serratus in anatomy lab, because I'm usually starting at that medial aspect of the scapula and looking for the deepest muscle and seeing if it paths anteriorly. So there's kind of a cool way of showing that. So that's kind of it. We will do posterior in a different video. So thanks.